Welcome to The Explainer. Today, we are tackling a topic that has truly changed everything in lung cancer treatment. We're going to break down the latest guidelines on immunotherapy biomarkers for non-small cell lung cancer, which is stuff you absolutely need to know as a trainee. So let's jump right in.
And radical shift might be an understatement. For so long, the options for these patients were pretty limited. But as this quote from the guidelines says, we are in a totally new era. This isn't just another drug on the shelf. It's a complete revolution in how we think. We've moved from just poisoning cancer cells to actually empowering a patient's own body to do the fighting.
All right, here's how we're going to break it down. We'll start with what this breakthrough actually is. Then we'll get into the puzzle it created for clinicians. After that, we'll walk through how the new guidelines solve that puzzle, take a look at another biomarker you might hear about, and then wrap it all up with the key things you need to take with you to the clinic.
Okay, first up, a new era for lung cancer. To really get why these new drugs, these immune checkpoint inhibitors, are such a big deal, you have to understand the problem they were created to solve.
And the problem, honestly, was pretty grim. For decades, if you had advanced non-small cell lung cancer, your main option was conventional chemotherapy. And look, it helped some people, but for many, it didn't work all that well, and the side effects could be brutal. We desperately needed something better.
And then, bam, the breakthrough. Immune checkpoint inhibitors, or ICIs. The concept is just brilliant. These drugs don't attack the cancer directly. Instead, they go after the brakes on our own immune system. See, cancer cells can put up a protein called PD-L1, which is like a stop sign for our T cells. It's a secret handshake that says, hey, I'm friendly, move along. What these drugs do is block that handshake. They release the brakes, and suddenly the patient's own T cells can see the cancer for what it is and go on the attack.
And the results? Whoa, they were huge. This here represents a doubling of how long patients lived from a landmark trial. For the right patients, the ones whose tumors had a lot of that PD-L1 protein, median survival jumped from just over a year with chemo to well over 2 years with immunotherapy. That's not just a small improvement. That is the kind of leap that changes the standard of care, like overnight.
Okay, so that brings us to the next chapter of the story, because this amazing breakthrough created a brand new puzzle. These drugs were powerful, but here's the catch. They didn't work for everybody. So the new challenge was, how do we find the people they will work for?
This became the million-dollar question for every oncologist out there. If these new drugs are the key, how do we find the exact right lock? How do we predict who's going to have that amazing response? Because giving someone a powerful therapy that won't work isn't just ineffective, it's a loss of precious time and can cause unnecessary side effects. Well, the answer, as you probably know, is in biomarkers. And for ICIs, the one you absolutely have to know, the main character in this story, is the expression of that PD-L1 protein we were just talking about. We measure it on the tumor cells themselves using a special staining technique called immunohistochemistry, or IHC. But of course, it wasn't that simple. Finding the right biomarker just opened up a whole new can of worms. It was suddenly the Wild West of testing. You had a bunch of different companies making different tests, all using slightly different antibodies and different rules for scoring. And to top it all off, the tumor itself is a moving target. PD-L1 levels can change. It was frankly a mess. Total confusion for the pathologist in the lab and the oncologist trying to make decisions. And this is exactly where these new guidelines are so important. They cut through all that noise and provide a clear, evidence-based way to solve this PD-L1 testing puzzle.
So, recommendation number 1. It's the big one, and it is crystal clear. You have to use a validated PD-L1 test. No exceptions. Think about it. Using a test that isn't proven to be accurate is just a guess, and we can't be guessing when a patient's treatment and their life is on the line.
So what does a validated test even mean? Well, this table shows you the big four. These are the FDA-approved companion diagnostics. And the key thing to see here is that each test is basically paired with a specific drug. They kind of grew up together, They were developed and tested side by side in the big clinical trials.
Now, in the real world, in your hospital, you're going to run into two types of tests. You've got these official FDA-approved companion diagnostics, or CDX, but you'll also see laboratory-developed tests, or LDTs. That's basically a test that your hospital's own lab has built. The crucial point from the guidelines is, if your lab is using an LDT, they have to prove that their test gets the same answer as one of the official ones. It's a huge responsibility on them to get it right.
So are all these tests interchangeable? Well, here's the good news. Studies have looked at them side by side, and it turns out that 3 of them, the 22C3, 28.8, and SP263, are pretty much interchangeable. They give you the same answer more than 90% of the time. But, and this is a big but, the SP142 assay is different. It's the odd one out, it tends to stain a bit weaker. This is exactly why you have to know which test or lab is using.
And another super important practical point from the guidelines is about how we talk about the results. It is not enough for a pathology report to just say positive or negative. That is way too vague. We need the number, the tumor proportion score, the TPS, as a percentage. Is it 1%, 50%, 90%? That specific number is everything because it's what dictates the treatment plan.
All right, so we've talked a lot about PD-L1, but it's not the only biomarker out there. Let's talk about the other big one you've probably heard about, another potential piece of the puzzle, tumor mutation burden, or TMB.
The idea behind TMB is actually really cool. Basically, you're just counting the total number of mutations in a tumor's DNA. And the thinking is, the more mutations a cancer has, the more weird, abnormal proteins it's going to make. And those weird proteins can act like little red flags for the immune system, kind of shouting, "Hey, I'm not supposed to be here. Come get me."
It's a great theory, right? Makes a lot of sense, but when you actually look at the clinical trial data, specifically in lung cancer, the theory just doesn't hold up. So the guideline is very, very direct on this. You should not be using TMB by itself to decide who gets immunotherapy for non-small cell lung cancer.
And this isn't just an opinion, it's based on hard data from big trials. A huge study called Checkmate 227, for example, ultimately showed TMB didn't predict who lived longer. Now, you might hear about this general FDA approval for TMB-high tumors, but here's the kicker. The study they based that approval on, it had 0 non-small cell lung cancer patients in it. So for our patients, the evidence just isn't there right now.
All right, we have gone through a ton of information. Let's wrap this up and boil it all down to what you actually need to remember and do when you're on the wards. So if you remember nothing else, remember these 4 things. Number 1, test for PD-L1, period. It is an essential step. Number 2, get the actual score. Don't settle for just positive or negative, you need the TPS percentage. Number 3, know what test your lab is running. It really, really matters. And number 4, don't use TMB on its own to make a treatment decision in lung cancer. Simple as that.
And let's end on this thought. These guidelines are the absolute best we have to work with right now. But let's be honest, PD-L1 isn't a perfect biomarker. The real future, the holy grail, is probably going to be combining everything, the pathology slides, the genomic data, maybe even having AI analyze it all to create a truly personalized prediction for every single patient. We're not there yet, but that's where we're headed. And that's what makes this one of the most exciting fields in medicine today.